Hi guys, and welcome to another episode. In today's episode review, we are going to be looking at a video from a Dr. Boz, very famous keto functional integrative doctor on YouTube. And I got to say, I'm actually really pleasantly surprised by this video. So thank you, Dr. Boz, for putting this one out. Today, we are going to be looking at this video, statins, what keto doctors don't tell you. Now, this video is actually a really, really good video. I'm really happy Dr. Boz put this out a little while ago because this is something I see a lot on YouTube. People giving half truths, people giving incorrect information, false information, sometimes just downright basically lies, unfortunately. Statins have a place, they have a role for the right patient at the right time for the right problem. And they're not evil. They do have a role and they can help some people. And look, I am a GP, I'm a doctor, integrative functional doctor, low carb specialist, and board certified lifestyle physician. My aim is always to treat things through diet and lifestyle changes, not through medications. And I love to deprescribe, that is, stop medications. Statins, I almost always am stopping them rather than starting them, but I do still start them for some patients. And Dr. Boz gives a pretty good reasoning why in this video. So let's have a look at it.
My total cholesterol is too high.
So is mine, actually, incidentally. Mine's pretty much exactly what Dr. Boz is, actually. And I'm not on a statin. I do not want a statin. I do not need a statin. But that's not the same as saying that high cholesterol is absolutely fine and nothing to worry about.
And most doctors would prescribe me a statin. If you watch this channel, you know that statins are not at the top of my prescribing list.
But they are on her prescribing list. Exactly the same as mine. They're very low down, but they're still on there.
But I haven't told you the whole story. Let's begin by stating statins are not evil.
They're not. They're not evil. And the drug companies, they're not evil either. They're there doing a business, trying to make money. And look, they have, I don't agree with them all the time. I'm not a pusher of drugs. As I said, I deprescribe more than I prescribe. But statins have a role for some people.
They do lower cholesterol, and that is one of the risk factors for heart disease, the #1 killer in America.
It absolutely is. Total cholesterol, LDL cholesterol, it is a known risk factor. There is an association with cardiovascular disease. Anybody that tells you otherwise does not know what they are talking about. They are frankly an idiot or they are lying to you. There is an association. But however, of course, as always, there's much more to the story, which we are going to cover in today's episode, courtesy of Dr. Boz. So thank you, Dr. Boz.
I do not think you should put statins in the water.
Yeah, believe it or not, that is actually a thing. That is actually a thing that has been advocated for on many occasions, and some doctors still advocate for putting statins in the drinking water, which is basically akin to just poisoning the population, in my opinion. And that is absolutely disgusting. And anyone that advocates for that is a total moron and is very, very ethically challenged. But yes, that is actually still a thing, believe it or not.
But when you look at people with the risks for heart disease and you're trying to reduce risks, cholesterol medicines like statins can improve that risk profile.
For some people, yes, it actually can reduce the risk. Again, something that you are not told by a lot of the keto carnivore doctors, hence Dr. Boz's video.
You've also probably heard me say that, yeah, we need cholesterol. Cholesterol is what makes our fat-based hormones. It's what's found in every cell with a nucleus, because if you want those cells to talk, they use cholesterol to do that.
Absolutely right. So cholesterol involved in cell signaling, cholesterol is involved in cellular repair, cholesterol makes pretty much all our hormones. Pretty much the same cell membranes are made from cholesterol. Without cholesterol, we literally would just fall apart at the seams, just disintegrate basically, which we don't want to be doing. Of course. Cholesterol is involved in so much in the body. So we do need to be extremely careful, I think, in my opinion, about reducing it and who we choose to reduce it for and when. But again, that's not the same as saying that anyone can just have a high cholesterol and who cares, which, as much as they may not say it, is the kind of intimation from a lot of the keto, not even necessarily the keto, but certainly the carnivore doctors out there.
And it's so important that any cell with a nucleus can make cholesterol. When you're a baby in development, making brain cells and all these important processes that require cholesterol, what was your total cholesterol? It was not 270 like mine. It was 50. How?
Yeah, as a baby, it's extremely low. And actually, there was a cardiologist not too long ago. I mean, I'd have to pull it up. I didn't save it, unfortunately, but they were on Twitter. It was known as Twitter, of course, back then, back in the day. God, I sound so old when I say these kinds of things. I am about to turn 40, though. And so, anyway, but yeah, basically, they were advocating for giving everyone a statin because they were saying, arguing that we should all have the cholesterol of a baby because when you're a baby, you have extremely low levels of circulating cholesterol. But that is because you don't need the high levels of circulating cholesterol like you do as an adult.
Well, your cells can make cholesterol inside them to use them. They do not depend on the transport of moving cholesterol around.
That's very true, both adults and babies.
Years of elevated cholesterol, yes, they have an increased risk factor for heart disease.
They do, which, as Dr. Boz correctly points out, is the number one killer in the United States and pretty sure across the world, at least in developed countries. And yes, high cholesterol is a known risk factor, but there's more to the story.
And that's why statins come to the table at all. That being said, I don't want to take a statin. So if they're good for lowering cholesterol and high cholesterol leads to heart disease and lowering it doesn't hurt you, why are they bad?
Yeah, I do not want to take a statin either. I really don't. But they can benefit some people.
Well, they do have side effects of muscle pain.
They do. Interestingly, my mum was visiting over from the UK. She was here for a month. She's actually just left this afternoon. I took her to the airport in Brisbane. She actually came over and was getting a lot of muscle pain, and she was on a statin. So she, independent of myself, I didn't even know, she actually just stopped the statin because she thought this might be causing her a lot of muscle pain. And hey presto, the pain went away. Interesting that, isn't it? She gave it a couple of weeks. Pain was completely gone. She introduced the statin again and bam, pain came straight back. Lo and behold, of course, it's the statin. So what did she do? Rightly so, she stopped the statin and the pain went away again. So she's going to go and call her GP in England and say she does not want the statin. Now, she actually has a family history of heart disease, but otherwise, her blood pressure is pretty controlled. She's on medications, but blood pressure is controlled otherwise. She is relatively low risk otherwise. She's had a clear calcium score. She's had a clear carotid artery Doppler scan. She's had a clear stress echo, and she's now pending a CT angio as well because she's actually a cardiac nurse and she works with all these cardiac surgeon cardiologists. They're just getting her in for everything to make sure she's all fine. Perks of the job, I suppose, if you will. But there's really all for nothing. She doesn't, really need them at all. So she's actually going to stop the statin. She's already stopped it actually because of this side effect of muscle pain. They can also potentially cause issues with cognition. There's a lot of anecdotal reports. There's not very good evidence otherwise, but very much a lot of anecdote that they do potentially impair cognition, your memory, and so forth. Whether or not they increase the risk of dementia, that is, I suppose, a possibility. Again, the evidence is lacking, but there is certainly a suspicion, let's put it that way, out there for that, as well as a whole heap of other potential side effects with statins. Interestingly, you may not know this, for the most part, most people, on average population, you are more likely to get type 2 diabetes from taking your statin than you are to prevent one non-fatal heart attack. Let's just let that sink in for a little bit. You're more likely to get type 2 diabetes, which is the biggest risk factor for cardiovascular disease, in the order of about 10 times as high. You're more likely to get that than you are to prevent a non-fatal heart attack. Isn't that interesting?
Thousands of patients have taught me that their brains do not work as well when on them. And it does.
Which is anecdote, but as Dr. Boz is pointing out, thousands of patients have kind of shown her this. I wouldn't say I've seen thousands of patients with that particular side effect, and I've treated a lot of patients with statins over the years. I've been practicing for almost 20 years now, over 20 years of medical experience, practicing for a long time. But Yeah, certainly some.
Does calcify their arteries. And although that can be helpful in a select number of patients where they're about to have a heart attack, I'm not sure I'd do that to everybody. Let's take a closer look. Teaching about cholesterol can be very confusing, so stick with me. So let's start by looking at a lipid panel. This will tell us what is your total cholesterol, what are the triglycerides.
And these are kind of like the general recommended ranges. Of course, these are in American units. So if you're Australian like myself, you'd have to convert these, but this is a kind of a standard, recommended ranges.
What's your HDL? And then finally, this bad cholesterol called LDL. What we're really looking.
Okay, it's quote unquote bad. It's not actually bad as such. What she's talking about there, I cut her off just a little bit prematurely. I have watched this video a number of times. This is about the fourth time I'm trying to record this video. My my video just keep crapping out. So hopefully this is going to record okay. What she's going to talk about is the bullet. And the bullet, unfortunately, Dr. Boz doesn't really quite explain in this video, which I think she could have done, which would have been just been the icing on the cake, if you will. But the bullet is the oxidized and damaged LDL, and that's what we want to avoid.
For is who has the bullets, whose LDL cholesterol is going to kill them. When you look at cholesterol traveling around our blood from one location to the next, it actually travels in lipoproteins, or these spheres or balls filled with triglycerides and cholesterol.
Yeah, basically little balls of fat floating around your bloodstream. The important thing there, though, is they're not individual balls of fat. Fat does not float around your bloodstream. If fat gets into your bloodstream, that's a pretty bad thing. You can end up getting what we call a fat embolus, which basically will just completely block the artery, and then it will basically cause things like heart attacks, pulmonary embolisms, and yeah, probably most likely death. Fat embolisms are very serious. LDL, lipoproteins, I should say, are really what carry around the fat within the body. So if you've got a very high level of LDL, most likely you are carrying around quite a lot of fat in your bloodstream. Now, that may be for a very good reason, or it may be for a bad reason. Doing a simple LDL panel, you can't, unfortunately, really tell that. But think of these things like little buses or little lorries kind of just trucking around the fat in your body. The trucks are not the problem here. It's what can happen to the trucks that's the issue.
These are called lipoproteins, and on the outside of those lipoproteins, we have these markers, either ApoB or ApoA. This tag on the outside tells the cells what's on the inside.
Generally, ApoA is considered to be healthy, ApoB considered to be generally unhealthy, in the same context as HDL being the quote unquote good cholesterol, LDL being the quote unquote bad cholesterol. There really isn't any good or bad. And that's a criticism of things like ApoB checking. It's maybe a better risk factor than LDL, but it's still not that good because of just what it represents, unfortunately. The other thing is pretty much all the calculators online for risk stratification that we use as doctors to guide our prescribing and stay within the guidelines and so on, which as much as they are guidelines, they are basically effectively quote unquote the law when it comes to medico-legal kind of things. If you're not following those guidelines, you will be pretty heavily criticized unless you have a good reason why, which is why a lot of the kind of low carb keto doctors and things, they've been criticized over the years. It's much more we're much more able to do this work now, and I am a low carb kind of keto doctor. Primarily, I do also teach carnivore. I know I'm slightly critical of carnivore, but I do still use it and utilize it with my patients where it is appropriate. But the thing is here, you have to really know your stuff, and you have to be able to back up what you're saying. And unfortunately, some people are telling people half truths, like I've mentioned in other videos.
It was years into seeing patients before I actually learned that the LDL cholesterol, that terrible bullet, was a calculation, and that the math is messed up.
I don't think it's that messed up, particularly. I mean, the calculated LDL works out almost entirely the same as directly measured LDL. It's really not that much of a difference. It's certainly nothing that you would need to worry about in any shape or form for the 99.9% of the population, if not 100%. You really don't need to worry about the difference there between calculated and directly measured LDL. It's a buzzword for people to make it sound like, again, LDL is pointless and stupid when the reality is that's actually not the case.
Example, in a lipid panel, we take several of these spheres, these lipoproteins, and we pulverize them. We take all of the cholesterol, put it in one section. We take the triglycerides, put it in a different section. And then we take the markers from the outside, and actually, we hardly look at those. That total.
Like I said, we do sometimes. I mean, I sometimes will do an ApoA1, ApoB and look at the ratio, and that can also give you a good idea of risk factors. Again, the problem there is there's no calculators that are using this. So, and I don't think it provides enough evidence, enough data to be useful outside of those calculators. So I pretty much always just do a lipid subfraction, which is a full breakdown of your LDL particles. I don't tend to do HDL subfractions because they're more expensive and generally not needed. I don't think there's any real benefit in doing that. But I do the LDL subfractions, which gives you here in Australia, gives you the LDL, VLDL, IDL, etc. And it's an incredibly useful test to be doing. It really gives you the exact size, shape, quantity, quality, whatever of the bullet that Dr. Boz is talking about here. That's that small, dense LDL. You can tell instantly how bad your LDL cholesterol actually is.
Cholesterol.
And it costs like maybe $125 here in Australia. What's that in American? Like 75 US dollars, maybe. It's like, it's hardly anything. And you can just get absolute clarification. It's a no-brainer to me, but I'm not the one paying for it, of course. But almost all my patients, when I tell them this, they're like, yeah, definitely sign me up. I'll do it. I'll do it now. Like, you know, they obviously have to fast and wait for it, but they really want to get it done. But a lot of my colleagues in the low carb space, I don't know why. They seem to just not see the benefit of this test. They seem to not want to do this test. I don't know why. I don't know if it's the cost or I really don't know what it is, but they just don't seem to want to do this test.
Comes from all of the lipoproteins that are in that blood sample. And the triglycerides also come from all the lipoproteins. This may not sound like a big deal, but hang with me. As we look at the smorgasbord of lipoproteins, again, the one we really care about isn't just LDL cholesterol, it's the LDL cholesterol that acts like a bullet.
And that's where ApoB isn't that much better, because it still doesn't really differentiate between the normal and the damaged LDL. And that's what she's talking about here, the damaged LDL, the small dense LDL, the oxidized, LDL, the glycated LDL. That's what she's talking about here. ApoB can't really tell you that, unfortunately.
Let's see.
The only thing that can really tell you that is that lipid subfraction.
How we find that.
Well, you can do a small dense LDL, which will give you the same information, or an oxidized LDL. Some people say you could do an LP little a as well, lipoprotein little a or lipoprotein little a. It's still not good enough, in my opinion. And it's just, why waste the time and the money, just effort, just do the bloody lipid subfraction and just get the absolute result that you're looking for. It doesn't make sense to me not to do it.
For starters, right after you eat, your body packages triglycerides and cholesterol into the largest of the lipoproteins, called a chylomicron. But you don't draw your cholesterol level right after you eat. You fast for at least 12 hours.
Which incidentally, fasting can push up your total cholesterol and LDL cholesterol. Doesn't really do anything to triglycerides particularly, or HDL. And the longer you fast, the higher it might actually go. Interesting tidbit, if you're here in Australia, where I practice, if you tell the lab that you fasted for more than 12 hours, very often they will actually just refuse to do your blood test. I have no idea why. I really don't know why they do this, but they will pretty much just refuse to take your blood test. So, and for some patients, like if you go and eat like a 2-kilo steak, I mean, no one's eating 2 kilos of steak, but a kilo tomahawk, like I can finish off a kilo tomahawk. And yes, I've got a little bit of weight to lose and so on. I'm trying to bulk up, but I'm kind of getting there. You can see some muscle there. I can eat a kilo of steak, sometimes quite easily. On top of all the food I've eaten in the daytime, I'm going to have to fast for more than 12 hours to get rid of all of that floating around my bloodstream. But if I tell the lab more than 12 hours, they often just refuse to do the blood test. So I just tell my patients, just tell them it's 12 hours, even if it's longer.
And
as long as I know how long you've fasted for, then I'm good.
And when I look at the size of these monstrous balls of fat floating around your blood, well, they're gone after about an hour.
Okay, well, they're not really that monstrous. I mean, 500 nanometers. It's not monstrous, but relatively large. They're not blocking anything, though, don't worry.
In fact, if I see any of these 12 hours into your fast, I call a major problem is happening. Those chylomicrons.
It's interesting, actually. I mean, I got a patient, well, many patients with extremely high levels of cholesterol, some of which are not on statins. And I've said they don't probably need the statins because we've done things like the lipid subfractions, we've done carotid artery, scans, we've done CT calcium scores, even some patients CT angios I've requested for them and so on to show that there's really very, very little risk for them and they don't really need the statin. But they've been told by other doctors that, their level of cholesterol is such that they are going to literally just block the artery. Like the artery is just going to become this basically fatberg. If you put like baby wipes and kitchen roll and stuff down your toilet and it gets into the sewer system and so on, you can, develop these fatbergs basically. That's like what they're telling them is floating around their bloodstream. It's simply not true. There is basically no evidence to support this at all, that you're going to have these fatbergs floating around your body and just suddenly just block off an artery because your LDL cholesterol in Australian units is like, 12, 13, 14, 15. Which in American units would probably, I don't know, something like 500, 600 maybe. I mean, pretty damn high results, yes. But there's really no evidence that you're just going to suddenly just block off your arteries. But yet they tell them that.
Deliver most of the triglycerides, and that sphere goes from 500 nanometers down to around 50. So a massive drop in size. We now have labeled these, strangely enough, very low density lipoproteins, VLDLs. And these are in circulation for 2 to 6 hours. These also get rid of triglycerides.
The nomenclature is a bit funny with cholesterol in terms of the densities. Best not to really worry overly about why things are called what they're called. Just roll with it, basically.
It's by delivering them to any cell that's hungry for energy. By the end of their life cycle, we've reduced their size, and we're now several hours into the life cycle of this lipoprotein. Again, we drop off a bunch of those triglycerides, and now we have the bad cholesterol. Yes, that
quote unquote bad cholesterol. It's not actually bad. Oh, I've freeze framed her on a very interesting face there, haven't I? It's quote unquote bad. It's not actually bad unless it is damaged, that oxidized LDL. I don't mean to keep harping on about this, but it is a really, really important point. LDL in and of itself is not a bad problem.
LDL cholesterol, the bad one.
As far as we know, and to a point, perhaps.
Notice how there's hardly any triglycerides left. There are a bunch of cholesterol left, but we call it bad because suddenly these cholesterol are terrible?
No, they're not.
No, the LDL cholesterol actually can last up to days in circulation. We call it...
And it will go higher if you fast because you're likely going into ketosis. You need to mobilize fat around the body to be burned as a fuel source. LDL is going to go up because it's delivering that fat to where it needs to be in the body.
The residency time, how long does it live in circulation? And when we look at all of these cholesterols lined up together, again, we are looking for this special.
And the NMR that she's got on screen there, nuclear magnetic resonance, this is a panel that you can get in America. We don't really have this in Australia, where you can get a much better breakdown of your cholesterol and the oxidized LDL, small dense LDL, that kind of thing. And you can kind of find this quote unquote bullet that she's talking about here.
Bullet. So do I have them? Let's take a closer look. So let's start out 12 hours after I've eaten a meal, and they give out their cholesterol and triglycerides, but mostly triglycerides, to any cell that's hungry. So it's been several hours after I've eaten.
Not sure what cells they're meant to be. I think it's just meant to be a cell. It kind of looks like a muscle, but I guess it's just any cell really that needs the cholesterol.
And there are a few VLDLs in circulation. We are now going to watch the lifespan of what happens in my body. Take notice of how gorgeous that liver is. Yeah, there's no excess sugar or fat.
Also take note of how gorgeous her slides are. They're really nice, actually, Dr. Boz. I got to hand it to you. They're really, really very nice. I'm going to have to find how she makes them or something because they're really very nice.
I deliver triglycerides to the cells that need it. Those particles get smaller, and we start to change their label from VLDLs to IDLs. But also notice...
which is intermediate density lipoprotein, if you didn't catch what she said earlier, because I have been talking over her, of course.
How many of them are recycling back into my liver. As the size of those particles decrease, We changed their label from VLDL to IDL, standing for intermediately dense lipoprotein.
There you go. And she's talking about them being recycled up into the liver. That's what happens with LDL cholesterol, VLDL, etc. They basically get taken up into the liver by these receptors. And we'll come to it later in the video. I don't want to spoil it too much, but statins can actually increase those receptors. And that's how they really reduce the total and LDL cholesterol. But it doesn't really affect HDL overly that much. It can a little bit, but it doesn't also tend to affect triglycerides overly either. It can a little bit, but not that much. Triglycerides are a big risk factor for cardiac disease as well.
Before we graduate to an LDL particle, it's at the end of that route where the particle has given away all of the triglycerides it can, and anybody that did need cholesterol got it, but now its job is done. Let's tuck it back in the liver. If we look deep inside that liver, there are these catcher's mitts,
where it will basically just get more triglycerides, etc., be repackaged and off it's sent again, basically.
Or receptors that will take these particles and sweep them out of circulation, take them out of the residence of our bloodstream, and put them back in the liver where we recycle and start over again. This healthy chemistry set is constantly sweeping out the lipoproteins and emptying the blood
of the normal, non-damaged lipoproteins. I'll come back to that later.
So is this LDL? Is it bad in me? Well, part of that depends on how quickly did I bounce down these different sizes of lipoproteins, distributing out the triglycerides, and then recycling proteins back into my liver as quickly as they were no longer needed.
What she's referring to there, really, when she's saying the length of time, is the length of time that they're floating around the bloodstream. LDL doesn't just get worse, get more damaged and so on, just naturally by itself the longer it's around, but it has more chance of getting damaged if it's longer in the bloodstream, more chance of oxidation, more chance of glycation, more chance of any kind of oxidative stress and further damage. So if it's around the body for longer, it's just got more potential to become that damaged LDL cholesterol. And the longer it's in the body, the more potential it has to get damaged.
The number of bullets in my bloodstream will be dependent on how long has it been a resident in my bloodstream.
As I've said, the longer it's there, the more chance of getting oxidized and damaged and so on.
So let's compare this to someone whose insulin is high and they come and say, "Doc, I don't want to be on one of those statins."
Very, very common thing for people to say. Absolutely.
"I want to use the ketogenic diet to lower my risk of a heart attack."
People more say things like carnivore nowadays, but yeah, a lot of people say this thing. Problem is they don't realize they have to actually do it. They have to actually commit to making the changes. And you can't just change your diet. You have to change your entire lifestyle, or you basically just need the statin. You can't do it both ways. You have to either be healthy in its entirety, or you take the statin. You can't just go keto or carnivore and say, yeah, I'm fine now. Great, no problems. No, you have to actually be healthy in all respects.
Except her story isn't like mine. Her insulin has been high for years. And the first thing that did was stored a bunch of sugar in her liver. And when all of those storage spots were filled, she packaged them into glycogen. No problem, easy to get rid of those if you need to. But she didn't get rid of them. She stored even more energy and turned triglycerides into fat globules in her liver.
And this is fatty liver, which can be caused by either alcohol or not alcohol. Very helpful, I know. Not alcohol really refers to what we call now metabolically associated fatty liver disease, which basically means that you're getting this fatty infiltration into the liver and it's just being filled with fat. The liver processes fat all day long and it's quite happy to do so. It just doesn't want to be storing that fat anymore. It's in the wrong place and it's causing a problem and it's causing damage, further insulin resistance and further issues. And what Dr. Boz is going to go on to say, or actually I'll just let her go on to say it. I don't want to spoil it too much.
And now she not only has high triglycerides in circulation, she has a bunch of fat found in her liver. That high sugar, that high triglycerides, that fatty liver and high insulin are all markers of where her metabolism is. And
it's basically shit. to not to put too fine a point on it, if you're in this state, your metabolism is pretty shit and you're pretty damn unhealthy.
How
Fatty liver is essentially a pre-diabetic, pre-heart disease, pre-cancerous virtually condition. It is not a good thing to have. Yet I find it's almost always not taken seriously by patients. And unfortunately, by a lot of doctors as well. They think it's just, you're just a bit fat, no problem. They don't understand it at all. They don't understand the pathophysiology. They don't understand the processes. And they certainly don't seem to understand how bad it actually is for people.
we might want to reverse it. Her risk of heart disease goes up with each of those markers, as well as her age, high blood pressure, tobacco, and a few other risk factors.
Like alcohol and stress and drug use and so on. There's also, I do a lot of work with patients with oxalates, which are a really big key plant toxin that we are taking out on, say, a carnivore diet. And a low oxalate diet, I've seen make miraculous recoveries for all sorts of amazing conditions. It's really absolutely fascinating. And incidentally, almost all those things you see being cured from the carnivore diet, all these rheumatoid arthritises and so on, exactly the same can happen from simply a low oxalate diet. And there is certainly some suggestion that oxalates there is some evidence to support this. You guys can Google this. There is some suggestion and there's some evidence to support it that oxalates may also be directly damaging the endothelium, which is the lining of that blood vessel, which leads to cardiovascular disease and plaque formation.
11 essential vitamins and minerals,
Oh,
protein,
we got
fiber,
that.
low GI. Amazing.
Not
So let's
amazing.
take a look at that VLDL inside our patient. Her
Geez, can you like Weet-Bix in a box? I mean, bloody hell. Can you imagine anything so disgusting? Like literally just like sipping wet cardboard through a straw. Oh my God, it's so disgusting, the thought of it.
VLDL starts out about the same size as mine. As she dishes off those triglycerides, she creates smaller lipoproteins, but also leaves a bunch of them in her rearview mirror. There are lots of VLDLs that did not get recycled back into her liver.
Yeah, because the liver's completely full of fat. It doesn't want any more. It's going to start to resist. It's going to start to cause problems. And this is where you start to get things like just abnormal fat metabolism, because the way that your body is meant to be working isn't working properly anymore because of the damage you've done to it. But this is reversible. This is reversible with the right change in diet and lifestyle.
And as she proceeds
And stopping alcohol and all those other things.
down the cycle of decreasing the size of her lipoproteins, that LDL particle doesn't recycle back up into the liver as fast as it should. It hangs out in circulation,
Which means it's got more chance of getting oxidized and damaged and so on.
having a long residency time, and becomes that purple bullet. Let's dive back into her liver and see how these lipoproteins are processed. There's those catcher's mitts again, waiting for those lipoproteins to be recycled out of the bloodstream and into her liver.
Interestingly, though, those catcher's mitts, as she calls them, the receptors, they don't take up really heavily damaged LDL, small dense LDL. Maybe slightly damaged they will take up, but the more damage they get, the less they will actually take up, which is very interesting.
Except in this case, there are not very many of them. Yeah, the liver is full. It doesn't need any more of those inside. It's stuffed to the brim already. As those bad cholesterol run into the liver, the number of catcher's mitts or receptors, well, it's pretty small. In addition, that high insulin state that caused all this melted away or destroyed the slime layer that protects those particles from exiting the circulation.
That's called the glycocalyx, sorry, which is basically this kind of layer of mucus and glucose and all other bits and pieces in there. And glucose is not evil all the time, has some important roles as well. And basically that can get disturbed when you've got very high glucose states, high insulin state, etc. And basically, yeah, then that can also these LDL particles, when they're damaged and so on, can actually then get into the lining of the blood vessel as well and cause a lot of problems.
As these LDL particles look for a new home, they wiggle their way out of circulation and into the wall of your artery. Those lipoproteins do not belong there. And your immune system attacks, saying, get the heck out of here.
You do. So things like monocytes will come along and phagocytose them, which is like just kind of engulfing the whole thing. Interestingly, they don't really get rid of them. They just engulf them and kind of just They're just inside the cell. They will keep doing that. And the more they ingest, the bigger they will get, eventually forming what we call foam cells. They're literally just foaming because they're so full of fat. And really, that is the start of the plaque formation. So the more small, dense LDL you have, the worse it is. What Dr. Boz's animation here isn't really showing is that cholesterol normally, LDL will normally just go in and out of cells and all the rest of it anyway. It's not actually really that much of a problem. It's only if it's really damaged where it really actually becomes a big problem.
A few lipoproteins outside the circulation and inside your artery wall, and your immune system will keep up no problem. But when thousands and thousands and millions of them exit the artery and hang out in this artery wall, it creates this.
Which is not pizza, stuffed crust pizza, despite what it looks like. This is an arterial plaque, of course, one that's probably just about to rupture and kill this patient, most likely.
This is the pimple that will explode into your bloodstream, causing the heart attack. It's encased.
Yeah, think about that whole thing basically just kind of rotating around and just blocking that whole artery. Like, it's just a heart attack.
This is like this, that if I calcified this like a statin would, it actually can protect you from the popping pimple.
That's right. Statins will calcify soft plaque and make it hard. Think of it like putting a mesh over the top and just kind of stabilizing that arterial wall, thus most likely reducing significantly the risk of the heart attack if you already have extreme amounts of soft plaque. The question is, if they cause hard plaque, do they cause it in the absence of any soft plaque? And we actually don't know that. It's an intimation by some doctors, but we don't actually know that if that's true or not. We don't know. All we know is it can help to convert soft plaque into hard plaque, which actually does decrease your risk. So if you're very, very high risk, yeah, statins can actually be quite useful for you.
But that's not all that statins do. Statins, yeah, they increase the number of these. Those receptors decline because your liver is full.
But they don't necessarily increase the uptake of small dense LDL, which is really what ideally they should do to get rid of it.
And
So it can still be floating around your bloodstream.
statins restore the number of catcher's mitts so these LDL cholesterol and other lipoproteins can recycle and get out of your bloodstream without heading into your arterial wall. So here we are where we started. My total cholesterol is above 276. My triglycerides are 88, and my good cholesterol is 107.
Good, quote unquote. My numbers are probably pretty similar to Dr. Boz's here, I gotta say.
My bad cholesterol is 100.
I'd have to do the exact calculations, but yeah, they're probably pretty similar.
155. So why aren't I on a statin? For starters, here are the risk factors for heart disease, and I don't have any of these.
Thankfully, I do not either.
Let's get a little more specific. Let's look at my Framingham risk factor. As a 51-year-old female with elevated total cholesterol, no history of smoking, normal blood pressure, and a HDL cholesterol that's pretty high, my total risk of heart disease over the next 10 years is less than 1%.
Interestingly, HDL, whilst it's generally associated with a lower risk of cardiovascular disease, if it's too high, it's actually associated with an increased risk of cardiovascular disease. If you look at things like the ARIC study, which is really very interesting. Again, a lot of doctors don't necessarily know these things. This is another good example that she's using a Framingham risk calculator, which is a really, really, common risk tool to use. There's other things like QRisk and all these other things that we use. Basically, the problem there is it's still using LDL. So even things like the small dense LDL, which I keep going on about, lipid subfractions and so on, there's no calculators really using these as risk stratifications, which is really very, very annoying because they're so much better than total cholesterol and LDL. But most of these have been around for decades, long before we knew about things like small dense LDL. And the drug companies, of course, look, this is where They're not evil, but they are kind of evil. Trillion dollar business, basically, statins across the world. There's no incentive to change. There's no incentive to deprescribe. There's no incentive to change calculators and things to be better when you can just whack everybody onto a statin. The drug companies are happy. Doctors are happy because they get absolved of anything. Patients don't really care for the most part because they think they're getting protected. If they have a heart attack, well, they just get a stent or whatever anyway. Everyone's happy.
I would present to me asking if I should take a statin. The answer would be no. I fast every week. I work to keep my body weight down. My blood sugar is low. And I push my mitochondria to be the best health they can be.
Ideally, yeah, also do the small dense LDL, but yeah, she's kind of right here.
When patients present saying, I don't want to take a statin and I'm kind of keto, well, the risk is real and
Yeah, it really is.
high.
It is. And you can't be kind of keto. You can't be kind of carnivore. You can't be, maybe you can be kind of low carb. I mean, you can be kind of keto. I mean, technically, yes. It depends what you're meaning by it. I mean, I see a lot of people who are, carnivore, but they're actually really not. And they just eat a lot of meat, but they're also just eating garbage, pizza and takeaways and sausages and things all the time. And they're really not carnivore at all. I see people doing keto. They're not doing clean keto. They're doing dirty keto. They're buying all these crappy keto products, guzzling down seed oils, all the rest of it, just causing massive, massive problems for themselves. You really have to commit. And this is the thing with statins. You can either be healthy or you can take a statin. If you're healthy, you don't really need the statin. If you need the statin, by definition, you're not healthy. You can really be one or the other, but you have to actually commit.
In those cases, there's a lot of benefit for reducing the number of lipoproteins in circulation.
And statins also have the secondary benefit of the calcification and protecting, stabilizing, if you will, that soft plaque into hard plaque, which does significantly lower the risk of cardiovascular disease and heart attacks, basically.
I hope you don't have to use a statin. But if you're looking for a way to do that, you do need to be consistently keto. I have people near and dear to me, patients, friends, family members who say, I don't want to be on that statin. Teach me how to live without it. But they come with a history that's filled with cancer and radiation and high cholesterol numbers and uric acid and diabetes and a history of lots of medical problems.
And they're often just, unfortunately, not willing to actually put the effort in to make the changes that they need to safely be without the statin. And patients, no end of patients coming to see me to hoping that I'll stop the statin. I had a patient recently come in literally like 3 days after the heart attack. They were basically discharged from the hospital. They came to see me because I'd heard, I do this kind of work to stop the statin. And I'm like, no, because you're massively high risk, and I am not going to be responsible when you have another heart attack. Like, you should just carry it on, and we'll deal with it down the line when we actually get you healthy, not like 3 days after your heart attack.
That have landed them with a really high risk of heart disease. Some have already had a heart attack. And this is where I strictly remind them, YouTube is not the place for you to get medical advice. It is a place for you to come and get educated. And I'm really trying to do that with an honest assessment of what statins do and why they are so heavily prescribed.
Absolutely. And this is why I was so glad that I came across this video, because this is pretty much the exact conversation I have with people. I go into more detail with the small dense LDL and so on, as long as they're not kind of, going over their head. But yeah, basically, it's really important. Don't get your medical advice off YouTube. Just come for education, but listen to what people are saying and fact check them. Actually ask them for studies. If someone's telling you something, ask them for the studies. When I'm talking on my main YouTube channel, the Meat Medic, I pretty much will always reference the study if I can, because, and if I can't, I pretty much don't reference the study. Because it's really important, I think, that people can actually fact check and check what I'm actually saying. I always say to my patients, in real life, in my, face to face, do your own research. Check to see if I am telling you is correct. Please go and do that. I don't want them to take me on face value. I want them to do some research as well so that they're better educated. And I want them to come to me to ask questions as well, not just me talking at them.
And then return the responsibility back to you. Understand the science. Go to your doctor with this conversation. And if you don't want to take a statin, then Well, be like me and control several of these things, like is your hemoglobin A1C as low as you can get it? Is your
Which interestingly often goes up on the carnivore diet. If you guys haven't seen my other video reviewing Judy Cho's video on why carnivore diet glucose rises, you should probably check that one out. In my opinion, it's pretty much garbage and I don't think it should raise on the carnivore diet, but you can go watch that video.
uric acid controlled? Do you have an ideal body weight? And are you growing the hardiest crop of mitochondria possible? If you want to talk cholesterol with me, the first thing you have to do is control this number. Check out this video before we ever talk cholesterol.
And there we go, guys. So that was the video from Dr. Boz. Really, really good video. I'm so happy that she put this out there. This is pretty much exactly what I say to my patients in a nutshell. You can either be healthy or you can take the statin. You really, you can't, well, you can do both, I suppose. But, if you really have to be willing to put the effort in. If you're not willing to put the effort in, you're going to have problems. Thank you guys for listening to this episode. See you in the next one.